Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Warning: Patients at Risk, Applying Mews to Save Lives. And now, I'd like to introduce you to Angela Craig, who is our moderator today. Angela is a clinical nurse specialist in critical care for ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is also the sepsis lead at her hospital and is a Sepsis Coordinator Network Advisory Committee member for Sepsis Alliance. An expert in the field of sepsis awareness and management, Angela has published and lectured extensively at numerous nursing conferences and webinars on the topic of sepsis. Angela, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am. Good day, everyone. Thank you, Emily, for that kind introduction. The title of today's webinar is Warning: A Patient at Risk, Applying Mews to Save Lives. Speaking today on this very timely topic is a colleague and friend of mine, Barbara McLean. Barbara is the evidence-based practice critical care clinical specialist for the Division of Critical Care at Grady Health Systems in Atlanta, Georgia. She is a member of many professional organizations, including the American Association of Critical Care Nurses, the Society of Critical Care Medicine, and the European Society of Intensive Care Medicine. She is the recipient of the Excellence in Education and Circle of Excellence for Clinical Practice Awards from the AACN and multiple awards from Society of Critical Care Medicine. She has written over 26 chapters, 17 articles, and is a regular reviewer for Critical Care Medicine, Intensive Care Medicine, and New England Journal of Medicine. She is a member of the founding work group for initiation of Mews. She is an educator and developer of advanced concepts in rapid response recognition and interventional methods. The disclosure for hers today are the following: Edwards Life Sciences, she is a consultant and on the Speakers Bureau, and La Jolla Pharmaceuticals, she is on their Speakers Bureau. Now, continuing education for nurses and respiratory therapists, this educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar, and the accrediting statements are listed here on this slide. We would like to thank Philips for support of this educational activity. And now, at this time, I'm going to turn this over to Barbara. Barbara, are you ready to start the program?
Yes, I am, Angela, and thank you for that great introduction. Angela is a wonderful colleague and friend, and we work together in many initiatives to try to stop sepsis. And what I'm going to be talking about today, applying Mews or even News to save lives of patients who are at risk in your hospital, on your wards, in your ED, and in your ICU. And my focus today will be very particular. I would like to actually discuss the learning objectives, and at the conclusion of this session we're going to understand and discuss the purpose of aggregating vital sign scores and correlating that with laboratory results. That's what helps us to differentiate the 4 major methodologies that we talk about in identifying patients, and particularly patients in sepsis: SIRS, QSOFA, Mews, and News. Lots of initials, but at the end of the program you will certainly understand what they mean. And I'm also going to talk about how we apply our aggregate information in a case study approach. And so to begin, I don't think that anyone would be surprised that there's just way too much information at the bedside. We know that in a critically ill patient, we can see up to 4,000 data points in 1 hour. And many of my intensive care colleagues, my physician colleagues in particular, who discuss that it's very difficult to actually aggregate all that information to make a good prediction about what's going to occur for patients. But we know that if we can identify patients who are at risk early and identify the immediate problem that might end their life, we're actually going to be able to make a change in our practice and make a change for patients who are at high risk for actual or potentially life-threatening problems. And again, particularly sepsis, but not only sepsis. We know that in our wards, in our ED, and in our intensive care units today, patients are incredibly vulnerable and they become so complex. And these complex patients are walking a very fine line between compensation and decompensation and even death. So our goal and our idea is to try to restore methodologies that allow us to provide early prediction and early intervention. Now, the NEWS guideline, what that stands for is the National Early Warning Score. You can Google it and you'll find all sorts of information. The National Early Warning Score comes to us from the UK, where actually Modified Early Warning Score also began. And from the NEWS guidelines, the most recent publication, 2017, there was a discussion about what all medical and nursing staff should be able to do. And you can see that this is a very nice list about assessing patients and understanding abnormal physiologic parameters and other abnormal observations. The patient just looks bad, and how to apply early interventions for those patients who are deteriorating, responding in the event of severe or rapid deterioration, and secondary to, of course, any emergency assistance, and be able to communicate information in a succinct manner. And that's a real struggle. It's a real struggle when you're in an acute situation with a patient who's deteriorating to focus on the meaningful data and to relay that appropriately to your physician colleagues or to the providers responsible for care. And then to actually undertake those tasks required to properly care for patients who are deteriorating. What I'm going to share with you here, it's not on a slide, but I really love this information. I just came back from presenting it in Singapore at the International Rapid Response Team Symposium, and there was an incredible lecture provided by one of our Singaporean colleagues who had actually looked at issues with implementation of rapid response for patients. And one of the most significant issues was physicians actually were concerned about the way data was supplied to them in regards to deteriorating patients. And we understand that it makes it really difficult when we're at the bedside because we might be on the ward, we might be on aquapheresis and telemetry, wearing a hospital wearable defibrillator, receiving drips that are in variable regulations, and we have 8 of those patients. That means that we're integrating information from multiple monitors, from special purpose monitors, looking at issues with our lead placement, the cost, the complexity, who's reading the EKG, is that somebody off-site in tele or telemed? We're not really certain about all that validity. Too much information, TMI, except here it's going to be TMD, too much data. And nurses are busy and they are very short-staffed. So really important to remind ourselves that our ultimate goal is we want to be able to perform tasks and always think. We want to perform our tasks that are necessary, but apply complexity to our critical thinking. But it's almost impossible in the environment in which we work today, in the high acuity of patients where we work today. I have to say I adore this slide, and unfortunately I can't claim credit for it. It's actually copyrighted from the Society of Critical Care Medicine. And the Society of Critical Care Medicine reminds us that we actually have to significantly identify patients at the intersection, for you to your left, at the intersection of how bad they look and the time. And you can see as time goes on, we don't have to assign how much time, but just as time goes on, degree of badness increases. And I think this is such a beautiful literal slide that just reminds us that our goal is to predict and identify patients who are at risk so that we can intervene quickly. Sometimes it's simple fluid, sometimes it's simple stimulation, sometimes it's BiPAP or just high flow nasal oxygen. But to identify patients at risk early, at the early intersection of time and badness, how bad they look. I love that slide because it really leads well to the understanding of trying to build chains of safety around our patients. So apart from patient safety initiatives, which are so incredibly important in terms of achieving better outcomes, it is very significant for us as providers, for us as nurses, to actually have a standardized methodology to observe the patient, document changes, and aggregate that information together to recognize deterioration of patients and then provide an actionable alert. And the key word is actionable. We can recognize that a patient is deteriorating, but that needs to be combined with an actionable alert. We want to be able to communicate appropriately. If it's staff nurse to charge nurse, staff nurse to rapid response, staff nurse to provider, whether it's APP, young doctor in training, the chief professor. How do we communicate appropriately? And how can we respond efficiently in a focused way to intervene, to evaluate our interventions, and to reassess where our patient is on the curve of time and badness? So in order for us to consider that, first and foremost, we have to think about system issues in patients who are acute or critically ill who are outside of the ICU. That's really the most important group that we're going to try to capture today. Those patients are so significant to remind ourselves that we can have beautiful protocols and beautiful pathways, and those are a mixture of process and application, but that no two people, and in this case, patients, are going to present and respond in the same way, even with the same diagnosis. We certainly see that with sepsis, that one patient who has the same infection with the same team actually gets better and the next one deteriorates. So we can't always predict how our patients are going to respond in decompensation. And when we think about our system and our complex systems applying complex care to complex patients, how we generally work with this is with alarms and alerts, the way our physical plants are laid out, meaning how many patients are on the floor, can you see them all at the same time, do you have a high level of visibility to their vital signs, or are their vital signs being measured every 4 hours, every 8 hours, every 6 hours, or maybe even every 12 hours, and what are we missing in relationship to that? And then we think about as basic providers. So of course, we're not just talking about our great big team, that includes everyone, but the team of the bedside nurse to the charge nurse, to the physician, to the specialist, and of course, integrating in there, if you're lucky enough, to have APPs. That we're looking at a lot of individuals getting data, and we want them to receive data in a reliable manner so they can apply their care to their patients in a reliable manner. Now, the problem with that, and especially in an institution like mine, the most fabulous place to work in the world, Grady Health Systems, a huge hospital with 2 medical schools providing care to all patients regardless of immigration status or ability to pay. We provide care for everyone who needs it. But what that means is we're taking in patients who have very significant comorbidities, maybe never saw a physician before, and the goals of therapy and their actual diagnosis is often unknown or frequently changing. So remember, what we want to do is put a chain of safety. And actually, I'm going to say it a different way. We're going to build a chain of safety, but we're going to put our arms of safety around these patients. And we're going to try to actually evaluate them appropriately when they are giving signaling of decompensation. So it is important, and when you look down at the bottom and you see what my references are, this is important to correlate to how long we've understood about the prediction of aggregating scores to actually project the knowledge of patients who are decompensating. And we know that nearly all arrests occur in patients known to be unstable, and in particular, patients who have a rapid respiratory rate or who have shortness of breath have a very high risk of deterioration. We also know from multiple studies, and they've been reproduced and expanded upon, that the majority of cardiac arrests are preceded by deterioration of number 1 of respiratory status and number 2 of change in mental function. Not necessarily level of consciousness, but in terms of being able to integrate data and in an organized manner, becoming confused or agitated, or even, of course, requiring a higher level of stimulation for responsiveness. But what I think is most important, and I'm going to be so excited at the end of my talk to share with you our data, 66% of cardiac arrests have documented deterioration 6 to 8 hours prior to arrest. So what does that mean to us? It means to us, if we're vigilant and if we appreciate all the warning signs, we can utilize this in a predictive methodology, not just a reactive methodology, a predictive methodology to actually underscore those patients under our care who are at significant risk. So, having said that, I want to just talk very quickly about 3 of the common signs of deterioration. And then I'm going to correlate those to some further aggregated data that will give us a very significant, strong chain of safety. So first and most important, a rapid respiratory rate. Across the continuum of care from birth to death, this is the most important predictor of deterioration. But honestly, I think in practice, it's probably the least studied and the least reliably evaluated. But what I always say is, you should always assume that a rapid respiratory rate is compensatory for the presence of metabolic acidosis until proven otherwise. And what that means is, when you have a patient with a rapid respiratory rate, you must uncover the why of that rapid respiratory rate. And then if we correlate that to laboratory values, and really speaking first about chemistry, looking at the anion gap, which is the balance between positive particles and negative particles, which becomes wide in most cases, not all, of severe metabolic acidosis. If we have a blood gas, then we look at the base deficit or the bicarb, looking at a decreasing bicarb or a more negative base deficit as a predictor of metabolic acidosis. And oftentimes, what's really important to remember, that frequently the anion gap and or the respiratory rate are the only signs of occult metabolic acidosis. So very, very important for us to appreciate correlating our rapid respiratory rate to our laboratory analysis to actually have a more significant predictability about patients at risk. The second most common sign of impending doom and deterioration is tachycardia. But remember, tachycardia is only going to be present in patients who can manifest that. So if I've had a sinus node infarct, if I have heart block, if I have a second degree AV block, or if I'm on beta block therapy, my heart rate may not be very predictable. And that's why we talk about following the heart rate, but only in the context of patients who can manifest tachycardia. Now, tachycardia is anything above 100 beats per minute. So again, you are going to apply that in the context of your situation, but I want to remind you that a rapid heart rate is compensatory for increasing delivery of oxygen to the tissues when the tissues are hungry for oxygen. So this occurs in hypermetabolic states, hyperinflamed states. This occurs, of course, also when our patient is hyperthermic. Any reason their tissues are demanding more oxygen. So as well, you'll see this in agitation. And it may be the most valuable standard bedside indicator that tells us about tissue hypoxia as a just basic standard in evaluation. Following that, we're going to talk about acute mental status change. So I love talking about acute mental status change. We don't really have a very clear definition. What our neurology and psychiatric colleagues will tell us is to really evaluate someone's mental status if they are awake, is that you have to do an evaluation of their awareness. what they're perceiving. Is their thought organized? Now, for many of us who work in intensive care, we know that that's part of what drove ICUdelirium.org to help us evaluate the loss of organized thinking and the failure of perception, a true perception of environment. And that also is an important concept when we're evaluating patients at the bedside, not just a GCS. I always remind everyone, C stands for coma. And GCS is a way of looking at basic brain stem reflexes. Now, of course, if your patient is alert and awake, they're going to get a really high score. But the problem is we're not evaluating their ability to have organized thought and to have true perception of their environment. So we do want to remind ourselves that in a general homeostatic environment, that you maintain adequate blood flow to the brain because the brain is using so much of the oxygen that's delivered that we call the brain an essential organ. That means essentially dependent on blood flow and oxygen. And what we want to remind ourselves is that when we have an acute patient who's breathing fast, blood flow gets shunted to the diaphragm and away from the brain. So what we start to see with that critical patient who's breathing fast with inadequate blood flow, that they'll start to have a change in their level of consciousness, not from awake to unconscious, but from awake to disorganized thought, to agitation, and then ultimately to the requirement for more stimulation for responsiveness. And we now say that mental status change is one of the most important early signs of organ dysfunction. So we're very clear about this when we're evaluating patients. And here's the big issue. In general, we notify our physician colleagues when isolated criteria are extremely abnormal. Your temperature is 40, your heart rate is 130, your respiratory rate is 28. Your blood pressure systolic has dropped below 100. I had to apply oxygen. Your SAT has dropped. But frequently, we're not identifying the subtle signs of acute of prodrome or warning of acute deterioration. And those subtle signs may not, in a singular file, may not indicate to us that we have a patient who's deteriorating. And that means we might not be identifying deterioration before it actually happens. So it's one thing to call a physician when a patient is in extremis and is shocked, either from cardiogenic shock, hypovolemic, hemorrhagic, or sepsis. They're already shocked and they have a very significant abnormalities in their vital signs. Our goal is to prevent that from happening. And so what the literature advises us is that when you aggregate data, that is going to change your efficiency, and it helps us to reduce variation practice from attending to attending to attending, from APP to APP to APP, from shift to shift, from resident to resident. It helps us to reduce variation practice if we have a standard methodology of identifying those patients at risk. And way beyond SBAR, it helps us to facilitate effective communication. Because if I have an aggregate score that everyone's been educated to, and my patient meets the score that says this patient is at risk for cardiac arrest sometime in the next 6 hours, or has the potential for a respiratory arrest sometime in the next 6 hours, that takes away all of the variability of our communication as well. And this helps us to identify patients who are at high risk for in-hospital mortality. Now, I want to make sure we appreciate that utilizing aggregated data in a scoring tool gives us a higher level of prediction. It isn't actually about validation of how sick the patient is, but it's predicting about a patient who is entering the prodrome. And I'm going to explain the prodrome in this way. You stepped off the path at the Grand Canyon, and you're now going to go down. So this is the same thing. I can validate that you went down because you're already down. But what I want to do is be able to predict those patients at risk who are providing us with data that tells us that they are in a prodrome state. So we start off with our first scoring data. As everybody knows, that systemic inflammatory response syndrome, which was profoundly sensitive and not specific, was introduced in 1991 from the beautiful work of Roger Bone in the identification of patients with sepsis. And basic SIRS criteria is heart rate greater than 90, respiratory rate greater than 20, temperature up or down, and a white count that is up or down. And this was our prediction model for patients who we believed were presenting with sepsis. Now, please be sure you understand me. I am not saying that SIRS criteria are not important. They are important, but they're very sensitive and they're not specific. So somewhere in the over 120 intensive care unit beds in my hospital today, occupied intensive care unit beds, I am going to find that the majority of our patients meet SIRS criteria because it's sensitive and not specific. Doesn't necessarily mean that the patient's in prodrome, but it doesn't necessarily mean that the patient is in sepsis, but it does give us indicators of how sick they are. So we understood very clearly SIRS was sensitive but not specific. So we again look at that data. We look at that data that was presented to us in 1991, 1992, again in 2004, but which has been changed, of course, in the 2016 guidelines for identifying patients with sepsis. Now that moves us to the generalized ward tool that came out of the 2016 guidelines, looking at altered mental status using an AVPU model, which is basically alert, response to verbal, response to pain, or it's unresponsive. Using that AVPU model to look at altered mental status, for me, actually not good enough because I really want to look at organized thought, because you might be awake and alert, but you might have disorganized thinking. So I'm really interested in adding that into my evaluation. But we start with that altered mental status, which has become key in identifying patients. Look at the rapid respiratory rate, greater than 22 breaths per minute. That's a very predictive. And then patients who, in the context of their normal blood pressure, have a relative hypotension with a systolic blood pressure less than 100. And of course, remember, that's contextual. It depends on the patient and how the patient is, what their normal status is and what kinds of therapy you're actually providing to those patients. Now, SOFA or quick SOFA, that's the Q SOFA, quick SOFA, 3 categories, a lot more specific, but not very sensitive. So here's our problem. Between SIRS and Q-SOFA, one is very sensitive but not specific. The other is more specific but not sensitive. So we move from that to Mews, which is going to be more specific. And what you're seeing now is the basic Mews that we use at our institution. And I apologize. Sometimes when we're moving slides, we have a little change in the format. So the S came down on that second line, the E came down the second line, but I know you can appreciate. It's systolic blood pressure, pulse, respirations, temperature, and level of consciousness. So if we step up here and we look at 0, when we're looking up here at 0, what we're actually saying is if you're normal, you're going to get a score of 0. If your blood pressure systolic is normal, 0. If your pulse is normal, 0. If your respirations are normal, 0. If your temperature is normal, 0. And if you're alert, 0. So that's 0 plus 0 plus 0 plus 0 plus 0. It's totally 0. You're not at risk. You don't have anything that's abnormal. Now, that's a really lovely methodology for us to evaluate patients. It helps us to look at the aggregate of information, but it might not be as particular as you would like. And so now we're going to take a look at Mews. And Mews is the early warning score that's been nationalized and most particularly been applied by Dr. Chris Stubb and his colleagues in Wales, in the UK, and looking at that national early warning score, Mews, which takes your respiratory rate, O2 sat, supplemental oxygen, temperature, systolic blood pressure, heart rate, and level of consciousness. And now I want you to look, based on the evidence, a much more specific categorization of those parameters. And again, any deviation from normal, which is 0, actually will award you with a score. We're okay if you have 100% SAT. So you don't get a score for anything above the 96, but you do get a score for anything below 95. And if you're adding supplemental oxygen, you're going to get a score for that. It's not going to be predicated on how much supplemental oxygen, just that that was required. So again, we would add a score for each parameter category, and then we add the score totally together. So Mews is even more specific and more appropriate than Mews. Mews more than QSOFA, QSOFA more than SIRS. So we go along the continuum of evaluation, and I want to remind you that there are some categories that are relevant to all the scoring tools. So we look at your systolic blood pressure, your respiratory rate, and your level of consciousness. And we're going to do that in a comparative analysis, but very important when we think about this comparison. And again, now you're going to take a look at these, and we're going to remind ourselves that Mews has more aggregate of the data. And so in a simplified Mews, you can see that the first 7 parameters are checked. Mews is a different check with a different validity, and QSOFA and SIRS much less valid. But one thing that goes across the spectrum, so I love to point that out, is that respiratory rate. It's checked in SIRS, QSOFA, Mews, and Mews. And what that means to us as bedside nurses is we have to make a commitment to true validation of respiratory rate, not just, I think your chest rose and fall 3 times or 4 times in 15 seconds. I'm going to multiply by 4, and I'm just going to give you a 16. I'm really going to need to validate your respiratory rate because that's such a great predictor. Okay, so in my practice, in my institution, we love Mews. We've been working in a Mews model for just about 1.5 years. We modified it a few times, and it really has assisted our floor staff, our ward staff, in identifying patients at risk before they decompensate. And we have made this automatic. So it provides an early warning signal to our rapid response team. And in my hospital, the rapid response team is a group of highly trained, specialized nurses who come from critical care and emergency room. They work only for the overarching rapid response team. Under the rapid response team are those who respond to deterioration of patients at the bedside and those who respond to vascular access requirements for placement of PICC and for changing of central lines. Now, this team, I'm just going to mention someone here because I have so much admiration for them. Under the direction of Andrew Matey. Andrew Matey is an acute care nurse practitioner. He's been with us at Grady for 1 year. And again, at the end of this, you're going to get a big reveal and you're going to see this phenomenal work that's occurred with our rapid response team. 10 years ago, our rapid response team consisted of 6 nurses. Today, between rapid response and vascular access, we have 56 nurses. Now, we have a big hospital and we have a lot of acute patients, so not everybody is going to be able to do that. But what our early warning system does is it communicates to our rapid response nurse for them to come to the bedside, work with the bedside nurse to identify patients at risk, and to talk about communication with our physician colleagues to elevate or escalate the care of patients, to escalate the monitoring of patients, to make some determination about whether or not we need an ICU consult or a transfer to intensive care. But someone said to me a lovely question in the conference that I was just recently in, this lovely question saying, don't you think that having an automatic identification method that notifies rapid response about patients at risk actually decreases the bedside nurse responsibility? And I want to deal with that right now. Absolutely not. Too much data, too many tasks, not enough staff, and 2 heads are better than 1. So we use this as a teachable moment. Our rapid response team will come to the bedside for patients who fire a Mews alert to actually assist the bedside nurse with correlating all the information with the communication to their physician colleagues, and also it's a support system for actually advocating for patients. So I want to make sure you appreciate, right now we're using Mews, we're getting ready to modify, but we use the Mews scoring system as a segue to an appropriate, focused, scientific communication. And always at the end of that, the patient just looks really bad. And remember, degree of badness to time is an important concept when we're talking about evaluating patients. So the idea was really, when we started this, was would multiple scoring criteria help us identify patients with subtle warning signs much earlier? And reminding ourselves also that we were already into a model of code sepsis with sepsis identification based on vital signs, requiring the staff nurse to actually evaluate the patient and identify if the patient was at risk for sepsis. Once they identified that the patient was at risk for sepsis, that would be our time 0, and it fires a code sepsis. But what we were finding is, because we used primary SIRS criteria plus level of consciousness change, is that it was really sensitive and not very specific. And again, you'll see that in just a minute. So we're using those multiple criteria and aggregating the scoring of that multiple criteria. And oftentimes we'll have 2 alerts that fire, and it's okay because it's firing to rapid response, a sepsis alert and a Mews alert. And we have actionable interventions, most particularly for sepsis, but we also have actionable intervention for Mews in that we can request increased monitoring, we have a higher level of communication, we may escalate to an ICU consult or transfer to the ICU. So I do want to remind you that I think in the evolution of time, we can look at a national early warning score, NEWS, which is a modified early warning score. That's really what it is. MMEWS is modified early warning score, made national, and particularly the data coming out of Wales is phenomenal when we look at how that identifies our patient earlier. So we're now going to take a little clinical scenario, and you can see our patient here, right? His systolic pressure is 96, so he's going to get a score of 1. His pulse is 116, so he's going to get a score of 2. Very important. So now 1 plus 2 is 3. Respiratory rate is 26. So he's now going to get a score of 1. So now he's got a score of 4. Now if you have the new score, you also are going to add in his O2 sat, 1. And the fact that he has supplemental oxygen, he'll get 2 for that as well. And we're looking at his level of consciousness. That's his CNS evaluation. He's anxious and slightly confused. So his Mews score is actually 5. And his NEWS score is going to be more specific and more integral, and that NEWS score is actually going to be 7. Okay, so what does that actually mean to us? So very important for us to appreciate what it actually means. Now, first of all, I just want to tell you how we've made it actually automatic, and you can see this is our Epic flow sheet. We have worked so strongly with our incredible Epic team to actually build this automatically. So the bedside nurse or the patient care tech enter the real-time vital signs, and then they will be requested to, if the vital sign aggregation meets a certain number, they'll be requested to do a level of consciousness evaluation. And what you can see down below is the level of consciousness evaluation and the increasing scoring that can occur. So here you're looking at the calculation based on the vital signs, and then adding in the Mews level of consciousness. So this patient has a Mews score of 10. So one of the biggest issues for us is real-time, right now, adequate vital sign evaluation correlated to a level of consciousness. And we're relying on the bedside nurses and the patient care techs to actually provide that information to put real-time, right now, vital signs directly into Epic, and the score is calculated by epoch. We also look at the prior scores. So each time that patient's score changes, and of course, you're looking at this patient, you would already know that this patient is really, really at risk, but we saw that a little bit earlier. Now, we made him very abnormal and we gave him a big temperature, but when we aggregated his score together, he had a score of 8, and that is going to be significantly concerning. So again, we always want to remind ourselves that when we're doing Mews, we have to do a level of consciousness evaluation. This is our pull down bar that reminds us what we're assessing. And then I want to just talk about scoring. So first and foremost, I'm just going to talk about low score, medium score, and high score. I'm not going to tell you what score you would use in your own institution because you're going to develop that for looking retrospectively at the amount of patients who meet criteria for medium score to high score. So typically a low score group is a group that has an aggregate score of 1 to 4. A medium score group typically is 5 to 6, and a high score group is anything with a score of over 7. So you can see low score, we're going to increase observation. We let the nurse in charge know. Medium score, rapid response is going to be called. They're going to come to the bedside. They're going to facilitate communication with the primary medical team. And a high score group means that now rapid response will come to the bedside with their critical care competencies, their diagnostic skills, their ability to order by protocol, basic labs, to actually give fluid if that's what's necessary, and to actually promote a rapid transfer to the ICU. So again, everyone is going to have a different method of looking at score. So this is a basic score tool. This is not from Grady. 1 to 4, 5 to 6, greater than 7, and that's correlated as green, yellow, and red. And for us here at Grady also is a delta change of 2 for any score greater than 5. So here at Grady, actually, we use 5 as our cutoff point, and most of our patients who get admitted to our wards meet an aggregate score of 5, but we have many patients who will fire at 8, 9, 10, or 11. So really important. So one of the things that has helped us, it's not necessary for everyone, but for us, what's helped us is an automatic notification, which overcomes some of the barriers, meaning time-sensitive notification, the bedside nurse or the patient care tech recognizing abnormalities. Now, again, you're going to look at this patient and say, well, they're really abnormal. Well, they are, because their blood pressure's 87 over 75, respiratory rate's 21, heart rate's 127, and this is their first Mews score. And this tells us where the patient is, doesn't give you any PHI because there's no MRN, there's no patient name, but just the methodology of identifying. This goes to our rapid response phone. Our rapid response team then is able to see patients who have scores that are 6, 7, 8, 9, 10, and actually prioritize who they need to go see first because of the abnormality of the scores. Now, just remember, this overcomes some of the barriers. I can't get to the phone. I'm too busy. I'm not really thinking about what's happening. We automatically have a notification that communicates to our rapid response team. That brings those experts to the bedside and promotes a teachable moment. And just to remind you, 2 heads are better than 1. And as we move forward in the complexity of our systems and our methodologies, what we want to remind ourselves is that human factor may be the major barrier to actually identifying patients early. And so when we look at an automatic, aggregated evaluation notification, that helps us to overcome human limitations. So now I'm going to just give you a quick reveal here. In 2018, utilization of Mews correlated to a 40% reduction in cardiac arrest on our wards. Mews alerts fired 4,319 times, and 400 of those alerts were actionable in some way. So you're, I'm sure, gasping, 4,319 times, that's about 5, if we averaged it, about 5 to 6 Mews alerts per day. And you need a big team to make that part work. But we're working on making it more specific because we don't want it to fire so many times that we no longer are paying attention to the alert. So we're looking at considering news and adding urine output and also considering laboratory analysis as part of the process. So this is our data analysis, and you can just take a look at code blues outside of the ICU and the linear relationship outside of the ICU. So this is total, and this is outside the ICU. And you can definitely see that what we have been able to do is significantly reduce code blue evaluations or notifications. And you see that regression line that is telling us that this is working in our system. So we actually have to look at all cause, mortality, and risk, but very important in terms of the way we're going to identify our patients. So now I just want to remind you that we want to make things more specific. So right now we're doing a McLean-Matey modification, so we're going to call it M2 modification. It's based on the Rothman index, and it's actually applying scores to some common variables in your laboratory analysis. And because our rapid response team doesn't draw arterial gases, we're looking at venous sampling, point of care, I-stat evaluation of venous gases to actually give us a higher level of consideration. Now this is a work in process, so we're still molding it, modifying it, and plugging it into Epic. But I wanted to place it here because I want to actually validate that even though Mews is more specific than SIRS and QSOFA, Mews is even more specific and correlating laboratory data. So we'll do a look back. Right now we're talking about an 8-hour look back at laboratory evaluation and correlating that into our scoring tools. So remember what the literature says. We can empower our nurses to know when to increase monitoring and when to inform others of subtle changes, to create a general platform for the patient who is decompensating and losing function. It increased trust between groups, and it helps us to know when to contact, in addition to all of our other contact variables, when to contact our rapid response team or our MET, and when to notify physician, and gives us a platform that we can utilize when we're identifying. So I'm coming to the final part. We're just going to apply it to a case study. This is a 32-year-old African-American male, comes to the ED with a chief complaint of an alteration in mental status. He's not complaining about that, his wife is, and he has no focal deficits. But she talks about that he's been coughing with a lot of mucus for the last 4 to 5 days, and he started having very severe emesis and diarrhea for the last 3 days. And under our evaluation, he becomes progressively weak and sleepy and lethargic. So what do we need? What are we going to do? So you don't want to proceed to an absolute diagnosis to quickly say he's septic. You want to keep that thought in the back of your head because you don't want to begin down a diagnostic platform before you identify how at risk this patient is. So we're going to take a look at how at risk we think he is. Okay, so now we look at Mr. Sick and his first vital signs in the ED. His heart rate's 144, respiratory rate 23. His blood pressure is 100. Thank you. 100 over 70 with a mean of 84. And what you're actually seeing here, and beautiful population, I pushed my buttons too many times. So we just take a look at his systolic blood pressure, and his systolic blood pressure is actually acceptable. So that gets a score of 0. His heart rate is 144. So he gets a score of 3 for that. His respiratory rate is 23. So he gets a score of 2 for that. And he has lost his profound alertness and awareness, and he's responding to voice, and you're having to do steep stimulation. So 3 + 2 + 1 + 0 for those vital signs. 3 + 1 + 2 + 0. And that 0, of course, is for his temperature. So we're looking at him. He's got a score of 6. In our practice, he's going to fire a Mews. Okay, so also we want to think about ABGs, not double ABGs, chemistry, CBC, cultures, a lactic acid level, and a coagulation level. Because we understand that labs give us confirmation, that labs tell us about how sick our patients are, how rapidly they're deteriorating, and it helps us to evaluate when we have significant or moderate changes in vital signs or when something isn't quite right with the patient. And we want to use this to actually integrate response and intervention and a higher level evaluation before a significant and profound change in vital signs occur. So remember, the goals of implementing Mews or News is to put arms of safety around our patient, to build a chain of safety, to evaluate patients who are profoundly at risk, to decrease your number of code blues, to efficiently transfer unstable patients to critical care, and to allow us to have a better level of physician communication and corresponding interventions. We're really happy because it's helped us to identify our patients at risk. It's helped us in prediction, not in validation. Patients in cardiac arrest now, that's validation, but to predict those patients at risk and to help us early on. So I'm going to turn it back over to you, Angela, for our question and answer time. And I want to just say thank you to Philips. Thank you to all of you for everything you do every day and for trying to improve safety and care for our patients. We are so lucky to be able to be together in this venue where we can reach many people all over the world. Thank you for taking your time, and I hope I've opened some questions for you. Thank you. Angela, take it away.
Thank you, Barbara. That was an amazing presentation. I want to remind everyone that the continuing education for nurses and respiratory therapists, that this educational activity is approved for 1 contact hour. To obtain your CE credits, you are going to go to saxtesting.com/BO, and you will need to register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. And support for this educational activity has been provided by Philips. So we do have quite a few questions. So we're going to get started with the first question. My first question is a question of interest that's basically about what can hospitals do, Barbara, if they don't have a fabulous Mews scoring process in place with a system that allows them to have this? What can they do?
Thank you. That's an excellent question. And I have to take that in categories. So first of all, if we don't have an electronic medical record system where we can make things automatic, and we don't have a well-trained rapid response team, and maybe we have rapid response, but those are nurses who are taking care of ICU patients, so there's a big continuum there. So let's just start with a hospital that doesn't have electronic medical record and a hospital that doesn't have a rapid response team. So first and foremost is, just like the educational initiative that we took, all of us in our hospitals around the world, to talk about utilizing SBAR. This is another way for us to talk about making information concise and cohesive on your patient. So when you have a patient who has small and subtle changes in one vital sign, you can use a paper scoring tool to actually propagate how profoundly at risk they are. But of course, that requires an initiative of the system and a commitment of the system that we're going to communicate to our bedside nurses and to all our providers what the value of aggregate scores are. And for many people on a ward, they may have patients who are not on a monitor, but they may have a portable monitor that they roll in and out of patients' rooms to do a vital sign check. And that would be the first place to really look at integration of a methodology that can be just based on that portable monitor, allowing them to actually have a scoring tool, and they can have a default that says what you're going to do if the score is 4 or less, 6 or less, or 4 or more, 6 or more. You can default that into your systems. But first, start with nurses learning about aggregating vital signs to actually identify patients who are at risk early.
Awesome. Thank you so much. So I do want to mention and clarify, you do use the EPIC system. Is that correct? I have a lot of people asking and are wanting that clarification.
We use EPIC EMR, yes.
Awesome.
That's not the monitor, but that's our EMR.
Okay. Wonderful. Now,
Electronic
Patrick,
medical records. Sorry, I just want to make sure. Electronic medical records. So pretty much everything we do now is actually input into an electronic record, and then building scoring tools from that is simple, and it doesn't matter if it's Epic. It could be whatever system you use.
and I do encourage people to at least reach out and find out maybe they can build something despite what system they have. There may be something they can do. All right, Patrick asked the question, how does the organization hold staff accountable for those with elevated Mews scores and no action is taken?
Oh, Eric, I couldn't have paid you to ask a better question. Thank you very much for that question. So I think one of the concepts is to have a full level appreciation that on the wards especially, we say floors, but ward sounds better, right? That our patients may be deteriorating, but our nurses are so busy, and we have so many acute patients, and most of the time we're short-staffed and we have some difficulty. So what we have done is our system has said, and the way we built it was that all patients who meet Mews criteria when vital signs are input, that goes automatically to rapid response. So we have decreased the human factor that is required for notification. So if you do your vital signs and you put them in, the request is for you to do a level of consciousness, but if your Mews score is greater than 5 even without level of consciousness assessment, that's going to communicate directly to rapid response. So it's really an identifier that has a reduction in human factor, and it actually provides us with incredible possibility when rapid response comes to the bedside to work with the nurse and say, look what happened here. You did a great job. You did the vital signs, you put them in, and this patient's at risk. And so along with rapid response, the decision is made about what to do, except of course if the score is really high, and then we escalate care.
Awesome. Sounds great. Mary Jo asks, do you recommend bicarbonate in metabolic acidosis, and why or why not?
Okay, that's such a great question. Okay, so first and foremost, I'm just going to share with you that I remind everybody that when we're looking at a patient who has metabolic acidosis, you really need to figure out what the cause is. The only time that I would recommend sodium bicarbonate is in a patient who has refractory hypotension, who does not respond to fluid and is having difficulty with responding to vasopressors, or if I know that I'm using that as a segue to get them to their primarily to their hemodialysis, or to their CRRT. When we administer sodium bicarb, we do two things. We neutralize your hydrogen ion for a very short period of time, and that's your metabolic acid. So we neutralize metabolic acidosis for a very short period of time, but that bicarb is actually going to disconjugate into CO2, which then puts a bigger burden on the patient to blow off CO2. So that's a problem. The second problem is if you're not identifying why your patient has acidosis, if you have time, to identify why the patient has metabolic acidosis and you give bicarb, what you may actually do is that change in the pH may actually make their acidosis worse, and much worse. But I think that might be a little bit beyond what we're talking about here today. It's a whole concept, but here's the thing. With assumed metabolic acidosis, I say ask three primary clinical questions for your chemistry. And that is, does my patient have DKA? So I'm going to look at hyperglycemia. Does my patient have high chloride? That's a buffer for metabolic acid that actually converts into a strong acid, hyperchloremia. Does my patient have acute kidney injury, not chronic? And then fourth, special lab required, does my patient have lactic acidosis? So I always remind you to look at the big four. And the one where bicarb is probably going to be quite beneficial is the person who's an AKI. Otherwise, bicarb is not going to be significantly beneficial, and I'm going to try to resuscitate the patient in other ways.
Awesome. Thomas asked this question, how often do you require med-surg and step-down floors to calculate a News or Mews score? He said his policy is once a 12-hour shift, but that seems too long to him.
I think you're exactly right. I think that's too long. I think patients deteriorate not on a time schedule. So our actual calculation is based on the input of vital signs. So on our high density intermediate units, those vital signs are performed every 4 hours unless the patient is a little unstable, and then every 2, and the Mews score is calculated every single time the vital signs are input. So I think that the separation here of the question is, how often should we be calculating Mews? We should be calculating Mews every time we do vital signs. The bigger question is, how frequently are you doing vital signs in your institution on a ward, and are nurses moving forward to increase vital sign evaluation in patients who appear to be mildly to moderately unstable? And I think the answer, quite honestly, is no. And so my recommendation would be that if a patient's in hospital, we should not do vital signs any less frequently than Q6 hours. But in many institutions, patients are getting their vital signs Q12.
Okay, great. And I hate to say this is the last question, but I do think this needs to be the last question. We have so many more that were phenomenal. We have posted an email address there. If you want to send those, you can. But I'm going to pick the last one as, what is the most important advice you would give to a facility just establishing a dedicated rapid response team? That's a hard one.
No, it actually is what I'm going to say. This is a journey. Having an active, assertive rapid response team is a journey. You may not know the right people to hire in the beginning. You think they're the right people to hire, but it isn't just about your level of evaluation and your critical thought analysis. It's also about the way in which people communicate. So it's a journey. And I think that patience is the most important thing. I think trying to set your rapid response team up with a basic protocols and basic agenda and a big flurry of introduction, like a hospital-wide celebration. Here's rapid response team. Here are the members. They're going to be at the bedside of your patients. They're going to help you. I think trying to implement rapid response on the down low, which oftentimes it is not a good thing. So I really do think that's one of the most successful issues, is to really implement them with a flourish, make sure everyone knows that they're there, make sure all your doctors and your APPs know that they're there, and that this is an addition, not a subtraction, from the autonomy of our physicians. It's an additional eyes and ears at the bedside. And that, again, I would say, just reminding ourselves, 2 heads are better than 1. But I do want to say something in final, is that my personal email address is in your chat. So it's pretty easy. It's BAM, like BAM, BAM clean at mindspring.com. And I'm very happy to answer your questions personally. I'm also happy to put you in touch with our Epic gurus to help you with an Epic integration, and I'm happy to share any of our documentation with you. And I'm going to say thank you so much for your great questions. And again, Angela.
Thank you. We're going to turn this over to Emily, the producer.
Wow, what a great presentation, ladies. Thank you so much, Barbara, and thank you, Angela, for being our moderator today. It's been a pleasure working with both of you. And with that, I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.